Good afternoon. Thanks everybody for hanging out on a Sunday afternoon. I know it's been an intense couple of days. I'm Robert Whirley, and I'm going to share with you a project I've been working on for the last few years on a novel approach to large bore vascular closure, the ARTERICA closure device. Some disclosures. I'm CEO of ARTERICA. I am not a vascular surgeon. I'm a mechanical engineer by training, the product of a misspent youth. I've been a serial entrepreneur in cardiovascular devices for about the last 25 years. I'm also chairman of the board of Nectero, which you've heard about, so I have lots of conflicts. But we'll get those out. Last year, Dr. Thomas Larson on this podium talked a bit about the scientific and clinical foundations of the ARTERICA device. I'll say just a little bit about that. I'm not going to go deep into that. I thought as a group, you might enjoy hearing a little more about it from the startup perspective. What else does it take besides just good science to bring a new device to market? In particular, I want to talk a little bit about the market in large bore closure, a sense of some of the preclinical testing, some of the early clinical work that we've done. I'll show you a couple of videos, including a cadaver study that I think gives you a good sense of how it works, and then we'll wrap up and talk about next steps. It's kind of surprising to me that here in 2026, closing large bore access is still pretty challenging. It's an interesting paper published in 21, the Choice Closure Trial by Abdel Wahab. It's a 500-patient RCT comparing suture-mediated closure to plug-based closure of large bore vascular access. And the takeaway for me wasn't so much which one's better, but high complication rates, 12 to 19% in both of them. And I sure don't have to share with this group the impacts of a complicated closure. Prolonged operative time, it's bad for the patient, it's bad for the doctor, it's bad for the hospital, and it really drives cost. Clinical complications are also prevalent. I won't take you through all this data. Look at the boxes at the top. The one on the upper left, this is an experienced vascular surgery center in Norway. They did a registry, greater than 800 patients, all the EVAR, TEVAR patients that were all intended to treat closure with the Abbott ProGlide device, 2 ProGlides per the IFU. Fully 1/3 of cases failed primary technical success, defined as they deployed 2 ProGlides per the IFU and the groin still bled. You had to do something. And bleeding also was a common complication found by Van Weechen in their study in the structural heart space, again comparing plug-based and suture-mediated closure. This is a significant opportunity, talking about the market size. This is also a $1 billion opportunity. If you look here in the green bars, I've shown the current procedure volumes for 2024. For EVAR and TEVAR, the largest single driver of these procedures, large bore procedures. TAVR and mechanical circulatory support may be something you're less familiar with. Think like the Abiomed Impella pumps, but there's at least 7 or 8 other startups that I'm familiar with. Think Magenta, Sapira, others that are developing technologies like this. That space is growing at about 20% a year. So in just a few years, that red bar is going to be out there with the others, and that's going to be another major driver of large bore access. So how does our device work? It's built on the surgical fascia closure technique that was originally developed here at Arizona Heart in the late 90s when large bore catheters were first coming out. That was a surgical procedure, less invasive than a traditional arteriotomy repair, but still a surgical closure. Today, the market's moved on to percutaneous devices when you can get them to work. Our approach has been to take the basic idea of surgical fascia closure and put that into a percutaneous device, which we think should work even better, given that you're not disrupting the overlying tissue. So the ARTERICA device is really differentiated from the other large bore closure approaches out there in 3 ways. Number one, we don't penetrate the diseased artery. We don't engage. That allows us to treat more patients. We're completely agnostic to the presence of calcification. And you might ask, well, how many patients have that much calcification? You probably have an intuitive sense. Fitzgerald actually published in Structural Heart in 2024, an analysis of the 500 patients in that choice closure trial. and found that about 1/3 of those patients, 30 to 35%, depending on which criteria you use, have enough calcification so as to significantly affect closure. Interestingly, that 30 to 35% correlates really well with the 1/3 of patients that failed primary technical success in the Norway study. So two very different approaches, you're kind of coming into the same conclusion. The second differentiating factor of our device is we leave nothing whatsoever behind in the vessel. No patch, no plug, nothing. Because it's an extravascular closure, we're wrapping the patient's own tissue around the vessel from the outside to achieve closure. So that doesn't inhibit reaccess. If you need to go back in an hour, a day, a week later to take care of a type 1 endoleak, no problem. Does not inhibit reaccess. Third, we keep a fully functional guide wire in place until hemostasis is confirmed. So if for any reason you don't get hemostasis, you can go back in with another ARTERICA device, you can go in with any other device you want, or you can put in inflated balloon, get control, then take the energy level down and decide what you want to do. The chart on the right just shows a comparison of the ARTERICA closure device against the Abbott ProGlide, which is the market-leading device in the space. We have one device for most patients versus Abbott needs 2 or more. Published data showed 2.2 or 2.3 devices are on average for closure. Second, it's easy to learn. It takes 6 steps. I could teach anybody in this room to deploy this device in about 5 minutes on the bench. And in fact, we had some visitors a few months back from a major strategic, and one of the manufacturing executives there was interested in the device. And so I walked him through the procedure, took him back to a bench model, handed him the device and said, let's do it. And so his hands, he did it, got a good closure in a bench model with 2 or 3 minutes of training and no prior surgical skills. So it's really easy to use. Finally, our experience in pressurized cadavers show that it takes 1 to 3 minutes to do these cases. So very, very simple. Now I'll show you a video. This is a conceptual video, not going to get lost in the engineering details, just to give you a sense of how this device works. We leave nothing behind in the vessel, and we burn no bridges, in that we don't do anything that inhibits reaccess. This starts at the end of the procedure. You got an 035 wire in place. You got the vessel. That plane there represents the fascial tissue. We'll take the subcutaneous fat and skin away. Insert the device over the 035 wire. Deploy a foot, seat that foot against the anterior wall of the artery for position. Then we'll adjust the handle into position, deploy 4 anchors that go through the fascia layer but not through the arterial wall. Tension the sutures that wraps that fascia up and around the vessel from the outside. That achieves the closure, bunches the tissue there. We then deploy a nitinol clip that holds those sutures in place, cut the sutures, and the device comes out. You confirm you have hemostasis, you're happy with everything, then the guide wire comes out, you close the skin in standard fashion. So pretty straightforward 6 steps. For preclinical work, we all know that the road to a successful large bore closure device is littered with bodies. There have been a lot of projects that started on this journey and did not come out the other side. And I think one of the big reasons is that they focused on using animal models for preclinical evaluation, and in fact, that doesn't work very well, I don't believe, in large bore closure, because the presence of disease in these access vessels plays such a big role. Everything works well in animals. So because of that, we've used a pressurized human cadaver model for our preclinical evaluation. By definition, cadavers have end-stage vascular disease, lots and lots of calcification, lots and lots of atherosclerosis. And so I think that's been a key step for us in defining the path forward. We did conduct a first-in-human clinical study, showed safety, technical feasibility, really happy with these results. We did 13 large bore cases. 11 of them had hemostasis almost immediately. 2 of them required some extended manual compression. Those were 2 learning curve cases on our part. In one of the cases, we inadvertently hit the skin when you saw those 4 rods come out and deploy the anchors. So we inadvertently hit the skin. In another case, we didn't get the device positioned correctly. We've subsequently addressed that with a 2nd-generation delivery system. I don't think we'll see that again. Even with that, we had 0 surgical conversions, no need for any ancillary devices. We had no access sites, stenoses at 30 days. In fact, I'll show you a CT image here in a second. No hematomas. Really happy with the results. And in addition to getting ultrasound, we did get CTAs on all 13 closures at 30 days. So we got a really good look at what they look like. Here, I won't take you through all of them here on a Sunday afternoon, but here's an example. And I don't think I have a pointer, but you can see there in the upper right. Oh, there's a pointer. Okay, so here's the access site, and you can see very cylindrical, nice healing, no evidence of that narrowing, that focal narrowing you can see after a suture-mediated closure. Very smooth result, very happy with that, and that was pretty typical. So our key conclusions from that study: we took all consecutive subjects in our size range. We didn't cherry pick for vessel disease, runoff, or anything. Deployment times were 1 to 3 minutes, as expected. No pre-close, so with the ARTERICA device, you don't think about closure till you finish the index procedure. And I'll wrap up with just showing you a couple-minute video that shows this is a pressurized cadaver closure. It's the next best thing to sharing a clinical case with you, but I think it'll give you a good sense of how the device works.
I insert the device, and I have blood return here. Then I open the foot and stow the foot against the wall and insert the handle to the click. And then I align the device, and I push the trigger, and then I tension the sutures. I stow the foot, and then I remove the positioner and deploy the suture lock and cut the sutures and take out. And I see no bleeding at all. You can increase to 140.
140, yes. Now it's 140.
I see no leakage at all. I see no swelling. You can go up to 160.
Now it's 160.
It's 160. Absolutely dry. Simulate the patient going up from the table and sit down in a deep sofa, and we do this stress test on to say now the patient is ready to ambulance after a few minutes. And we look now, and it's totally dry. And what's the pressure?
Still 160.
Okay, that was a illustration of a deployment pressurized cadaver. The blood model there again is non-coagulable. So this is an infinite ACT patient. So it is purely a mechanical mechanism of action. So that's a little bit about the device, how we've developed it, the results from our first in-human clinical, and you get a sense of what the procedure flow looks like. What's next for us? Right now we are raising a Series B financing. We're about halfway through that process. I would say we've got 2 co-leads, 2 global strategics involved in the deal. Beyond that financing, we'll move on, do an expanded feasibility study for the FDA, and then take that to a pivotal IDE, which will be followed by a U.S. pivotal trial and FDA approval. So thanks very much.
So right now, we don't have the name of the next lecturer, but there's supposed to be...
Can I ask him one question?
Sure, I'm sorry.
And maybe I missed it. First of all, very good presentation. What is the suture that you're using? Is it Proline? Is it Ethibond? It looks like an Ethibond.
It is nylon. And it is an FDA-approved nylon suture. And the reason you want nylon, as I mentioned, those 4 anchors, it is unlikely, except in cute little animations, that all of them will grab exactly the same amount of tissue. So you want some stretch in those sutures to distribute the tension equally as you bunch the tissue.
And you're pursuing 510K?
All closure devices in the United States are PMAs.
Oh.
So this is a Class 3, gives the same regulatory path than a AAA endograft is. That said, it is the easiest PMA you'll find. 30-day follow-up, 125, 150 patients, objective performance criteria. So nowhere near as challenging or expensive of a trial as an endograft or a TAVR device, but it is still a Class 3.
Extraordinary concept.
I'm sorry, say that again, please? Yeah, reimbursement now is covered under the procedural DRG, and that for closure devices, and that will be no different than ours. One could seek development of specific reimbursement for this device. I wouldn't rule that out. That is a long and very expensive process, and capital is simply too expensive for a startup at our stage for us to undertake that. But I would love to take that on downstream.